Okay, hello everyone. The next few lectures shall be devoted to understanding perimetry. First, the basics. The second lecture would probably be interpretation, and the third would be association between the clinical part of glaucoma and the perimetric part of glaucoma. So, the very first thing that we need to look at is a perimetry report. This is basically a Humphrey field analyzer report. There's a lot of different types of perimetry reports that are available depending on the machine that you're using. The most common and generally the gold standard considered is the Humphrey field analyzer. So this is what a Humphrey field analyzer report would look like. And understandably, the most interesting part is the center, this section, and this section of the perimetry report. But we cannot directly jump onto that when we are looking at a perimetry report. We first need to look at this section. Okay, there's usually the name of the patient, and why is name important? For demographic purposes, of course. And secondly, the surname of the patient can give an idea or as to the race of the patient and hence a likelihood for glaucoma. For example, African Americans are more susceptible to open angle glaucoma. Asians, especially the Southeast Asians and the Northeast Asians, are more susceptible for angle closure glaucoma. So the race itself will give you an idea as to whether this patient is susceptible for a particular type of glaucoma or not. Then there will be the age of the patient, as you can see right here. Okay, so now our focus is here on this section. Here's the age. Why is age important? Obviously because as the age increases, the susceptibility for glaucomatous damage also goes up. But second and more importantly, you are basically, when you're conducting perimetry, you are basically comparing the patient's results with a database of results. It's not an objective test where there is an absolute answer to any questions that you might have regarding glaucoma in this patient. You are basically comparing the patient's results with the database results that have been collected over several years by the company that is manufacturing the machine. And those results will vary based on the age of the patient. So say for example, if you put the age of the patient as 60, but the patient is actually younger, then those defects will be flagged and the reports will not be valid. So you really need to put a proper age of the patient at the time of conducting the perimetry test. There's a couple of other things. Usually there is also a numerical data such as 24-2 or 30-2. That is the type of perimetry test that is being conducted. This is 24-2. 24-2 has an asymmetrical appearance of the numerical values. There's an extra 30 over here. The other type will be 30-2, which is completely symmetric. There won't be any extra digits here or there. So what does 24 and 30 basically mean? 2 is a little more complicated to explain in this short lecture. Is basically the algorithm used. For now you can just remember that much. 24 denotes the degrees in which the temporal field, temporal to the fixation, will be studied. So this is the fixation point. The center is the fixation. Always and always in perimetry, the center is fixation, not the optic disc, not any other point on the retina. It is always the point of fixation, the macula, the center of the macula. So 24 denotes the degrees, 24 degrees of temporal field of vision that will be studied in this test. And the nasal field is always 30, that is fixed whether you pick 24-2 or 30-2, or there is a third variant called 10-2. So 10-2 basically focuses on the central 10 degrees around the fixation. So advanced glaucoma, when only the central fields of vision are left behind, are left intact, in those cases 10-2 protocol becomes useful. So it is temporal 10 degrees and nasal is of course 30 degrees, which is always constant. You are looking at something called fixation losses. So fixation losses are basically in an inattentive patient, a patient who is not paying enough attention during the test. So fatigue, tiredness, those kind of things are going to show up on fixation losses. So these are basically the quality parameters. These three are the quality parameters of any perimetry test: the fixation losses, the false positive, and false negative. False positive is when the patient is only given an audio input, but there is actually no image on the perimetry bowl that is presented. So false positive is when the patient does click the machine, the clicks the indicator even when there is no stimulus. So a trigger happy patient, as we call them. So false negatives are the most disturbing when you are conducting perimetry, because they deviate from the results very bad. Fixation losses is the second most important. The least important is false negative. False negative is basically, when you conduct perimetry test, the same point has multiple, stimuli given over the period of test, over the 10 or 15 or 20 minutes of the test. The same point is shown up multiple times. So false negative is basically when the patient is given a stimulus, the patient identifies the stimulus, and the second time you show it, or the third time you show it, or the fourth time you show it, the patient does not respond to it. False negatives should be less than 15%. Fixation losses should be less than 33%, and false positives should also be less than 15%. So a false positive test more than 15%, not a reliable test. You have to worry about this test, and you need to conduct the test once again, either on the same day, or you call back the patient when you think they have calmed down enough or understood the test enough. False negative does not necessarily mean that the test is unreliable. It could also be because it's an early stage of glaucoma. So when the glaucoma is early, there is an increased variation between the responses. The same area, even if the patient is giving their best possible effort, it might still indicate that there's an early stage of glaucoma, and the same point might show variable results over a period of time. That is entirely possible. So it would be unfair to discard a glaucomatous test or perimetry test based exclusively on the false negative value. Test duration, not so significant, just gives you an idea of how much effort the machine has to exert to get a response from the patient. Stimulus 3 white, it's basically a white on white kind of perimetry. In the subsequent lectures, we'll discuss the different types of perimetry and the variations in perimetry available, such as short wavelength automated perimetry, which is a blue on yellow stimulus. This is a white on white stimulus. The background is white, and the stimulus is also white in nature, of course brighter than the background, only then will it be visible. The background is generally fixed to 31.5 ASV. ASV stands for apostilbs. So why do you need a background illumination? Why can't you just leave it unilluminated? If you leave it without any background illumination, any outside light that may be present, there might be a small bulb, a small tube light, maybe it's a darkened room, but the moment you open the door, there's going to be some illumination falling on the bowl. That is going to create a disturbance in the interpretation of the results. So you want a common background illumination which will not interfere with the test results, but is bright enough to eliminate any outside influence of any stray light rays that might come into it. So you want a background illumination, and naturally the stimulus intensity will be brighter than 31.5 apostilbs. Strategy, there are multiple kinds of strategies available. This is the SITA, that is Swedish Interactive Threshold Algorithm. The other would be a standard algorithm, a non-SITA one. Advantage of SITA is it's faster, it is more standardized, but the disadvantage is that the patient needs to really pay attention during the test, because it's a shorter duration test with lesser number of stimuli. So any mistakes are going to be magnified. You make one mistake out of 100 stimuli, that is going to be the standard test. But if you make one mistake out of 50 stimuli, then the proportion of incorrect answers goes up as a percentage of the total number of stimuli given. Pupillary diameter is generally measured, and that is because a dilated pupil is going to cause interference in diffraction, and that is going to interfere with the results once again. So the pupillary diameter also needs to be looked at. Visual acuity, you will always give the patient full correction of his or her spectacles at the time of performing this test. Why do you want to do that? Because you want the best possible visual acuity. You want the patient to see the stimulus, and that is why you want them to either wear their own spectacles or preferably put your own trial lenses, because using your own spectacles, the spectacle has a rim unless you're wearing rimless spectacles. But if you're wearing a rim spectacle, the rim itself will interfere with the perimetry results and will result in artifacts, which will give a false positive scotoma in the test. Date and time only for linear time-based analysis. You would conduct a test, maybe 6 months later you would want to conduct the test, and hence you would want to know the date at which the tests have been conducted. So a serial monitoring and event-based analysis can be carried out. Okay, so now let's come to generally what I consider the fun part. let's look at this. Okay, so this is a threshold sensitivity map. What do you mean by threshold sensitivity map? This is basically a sensitivity map of the retina, whatever 24-2 or 30-2 that you have conducted. So this is the 24-2 protocol that has been carried out. So a threshold sensitivity map basically represents the threshold at which a given light stimulus is noted for 50% of the times by the patient. It is recognized by the patient half the number of times that the stimulus is shown. So it is not necessary that every stimulus needs to be noted by the patient. 50% is good enough. Half the times you are able to identify the stimulus, that's enough. So threshold sensitivity map has two parts. First is the numerical, and the second is the grayscale. It's pretty self-explanatory. You can see multiple numbers given over here. So what do these numbers mean? Let us start with the easiest part, this triangle. So the triangle represents the blind spot, and the blind spot represents the optic nerve head where there are no photoreceptors. So when it says 0, it means it is a point where no matter how bright you make the stimulus, no response is elicited. And that is actually a marker for, accurate fixation by the patient. The patient is not looking here and there, because this is supposed to be the fixation, the macula. This becomes the optic nerve head. And because the optic nerve head is, say, very crudely to the right of the point of fixation, this becomes your right eye. This becomes your right eye. This becomes your temporal field of vision. And this becomes your nasal field of vision. We'll come to why the right side of the right eye is temporal and why the left is nasal in the correlation lecture between clinical versus the perimetric findings. For now, you can just take it that this is the right eye that we are examining. This is the temporal half of the field, and this is the nasal half of the field. All right. So 0 represents the point of absolutely no sensitivity, and it is in an inverse manner. So the farther away I go from 0, the more sensitive the spot is, the lesser, even less bright stimuli are noted. For example, 30 is more sensitive than 27, and hence 30 has a higher sensitivity than 27. What does grayscale mean? Grayscale is basically a color based, a black and white based interpretation of the same data that is given in numerical. Only difference being that areas with a higher sensitivity, areas which are more sensitive, which means closer to fixation generally, will be lighter in color, will be whiter in color, and areas with a lower sensitivity, where there is likely to be a pathology, will be darker in color. So this is roughly a normal perimetric report. A little bit variation in the periphery is normal because the sensitivity is maximum at the fovea and decreases as you go away from the fovea into the periphery. So this is largely normal, but you could say, and you could prove physiologically, that the theory that central area has a higher sensitivity than something like periphery. This appears darker, so this area will be lower sensitive and less likely to respond to the light stimuli than the central part, which is what the physiology says. Okay, then let's come to the next part. So this needs to be read in this manner. Hold on. So the next 4 images needs to be read in this manner. These two need to be read together, and these two need to be read together. This is called total deviation plot, and this is called total deviation probability plot. Likewise, this is pattern deviation plot and pattern deviation probability plot. So let's first look at what total deviation means. As I said, this is compared to a database of normal values that have been calculated by the company that is producing the machines. So the total deviation is basically a subtraction of whatever the patient has given value, whatever the patient's readings are in this threshold sensitivity map. Subtract that from whatever you consider the normal database. Consequently, you are either going to get a 0 value, which means that particular point on the perimetric field has a sensitivity same as that of the database, which basically means normal. Or you could get a negative value, which means the sensitivity in the patient at that perimetric point is lower than the normal value, which means it's probably abnormal. Or you could get a positive value, which means the sensitivity is actually higher than normal. So all three possibilities exist. So total deviation is basically an arithmetic subtraction of the patient's threshold sensitivity map and the database that is present. What does probability map show? Probability map shows that the total deviation, what does the total deviation at a particular point represent? So suppose we pick this point, all the points are the same, so we can pick any point. So this point represents a probability of the point being abnormal. Absolutely not, because this is the legend that is present here. If you see these symbols in the probability plot, then that needs to be considered. Right now it's absolutely normal. A single dot does not represent anything. You can see 4 dots represents a probability of less than 5% of a perimetric point being abnormal. This symbol represents less than 2%. Likewise, a completely absolutely black dot, a black filled square, sorry, represents the probability of less than 0.5%. So if you get any of these in the probability map, that is when you need to start considering that there might be a pathology. Right now, no pathology at all, because this is a normal perimetry report. What does pattern deviation do? For example, okay, what does pattern deviation do? Pattern deviation basically adjusts for any generalized pathology in the entire eye. For example, if the patient has a cataract, the patient is going to have a depressed perimetry because the cataract is not going to allow those stimuli, the small stimuli, to reach the retina. Consequently, it is possible that you might interpret it as a glaucomatous disease, whereas it is actually because the diminution of vision and an abnormal perimetry would be because of the cataract. Because remember, perimetry could be abnormal not just in glaucoma, but in a variety of neurological and anterior segment conditions such as glaucoma, corneal opacity, so on and so forth. So the pattern deviation adjusts for such generalized pathologies that might be expected in the patient. How does the machine do that? There's algorithms, and we'll get into a greater discussion when we talk about the clinical correlation. But there's a machine-based system. You don't have to do anything. It's the machine who decides based on the age of the patient, the refraction that you've entered, so on and so forth. So the pattern deviation is considered more accurate, is considered more reliable indicator when you're expecting a generalized pathology in a patient. So that's again similar. These values are a subtraction of the pattern deviation values from the normalized population, and this pattern deviation plot probability map is again similar to the total deviation probability, where the probability of a particular point being abnormal is judged. There's just a single point which could show a probability of less than 5%, but just one point in the entire retina less than 5% is not significant. You need a cluster of there's actually multiple criteria, and there are 3 criteria amongst which any one, if positive, should raise a suspicion of an abnormal glaucomatous, of an abnormal perimetric test. The first is a GHT abnormal. What is GHT? That's exactly what we're coming to next, but for now just note down GHT abnormal. The second is a mean deviation, no, hold on, it's pattern standard deviation less than 5%. That again will come back when we talk about pattern standard deviation. And the third is a cluster of 3 points in the PSD. For example, if these 3 points, if we are considering, or any variation of 3 points on the pattern deviation probability plot, any 3 points which have a probability of being abnormal less than 5%, and at least one of which will be less than 1%. So a total of 3 points, at least 3 points, it could be 4, 5, 6, but at least 3 points, all 3 which have a probability of less than 5%, and at least one of that cluster should have a probability of less than 1%. So this is called Anderson's criteria and is used to decide whether a perimetry report appears abnormal or not. So coming to GHT, what does GHT mean? GHT is glaucoma hemifield test. What you're basically doing in GHT is comparing the superior half of the glaucoma of the perimetry field with the inferior. There's a certain set number of points, set area of points that are compared of the superior and the inferior halves of the retina, and because glaucoma is asymmetric both in between 2 eyes and more importantly along the horizontal horizontal midline, meaning the defects in the superior half of the retina usually do not correspond to the inferior half of retina in a glaucomatous eye. The GHD will be abnormal in almost all cases of glaucoma because of this principle of asymmetry. VFI is visual field index. It's basically a numerical value which tells you how good is the visual field right now. 100% is basically absolutely normal visual fields, everything is working fine. 0% would not necessarily mean blindness, but it definitely means a perimetrically blind eye, an eye which appears blind on perimetry. So that is VFI, visual field index. Mean deviation is basically a weighted average. Weighted average meaning not a regular arithmetic average, but an average. We'll come to weighted average. So mean deviation is basically is a weighted average of all the values of the total deviation. So you take total deviation, you carry out a weighted average system, you mathematically carry out the weighted average, and you come to a value which could either be again 0, which means normal sensitivity, positive, which means better sensitivity than the database, or negative, which means a depressed sensitivity. So what does weighted average mean? It's a mathematical concept. Not all the points on the retina are given equal importance. The points closer to fixation would be given more importance than the points on the periphery. Naturally, if you have a defect, if you have a smaller defect closer to fixation, that would be given a greater weightage compared to maybe a larger defect in the periphery, which does not matter as much to the patient's vision. So that is mean deviation. Pattern standard deviation is the counterpart for pattern deviation. Again, the values could be positive, negative, or 0, and the principles remain the same. So that's basically, in brief, what you should be looking at when you're looking at a perimetry report. I hope this lecture is useful. We'll get into more detail as we discuss more of perimetry. And thank you for listening.